Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
Hello, I'm Sean Wharton, Assistant Professor of the University of Toronto and Medical Director at the Wharton Medical Clinic in Toronto, Ontario, in Canada. So welcome to this program titled Rapid Fire, Your Questions Answered on Obesity and Liver Disease. I'm joined today by Dr. Aaron Senyal, Director of the Stravitz-Senyal Institute for Liver Disease and Metabolic Health at the Virginia Commonwealth University School of Medicine in Richmond, Virginia, in the United States. Welcome, Aaron.
Hi, it's great to be joining you today.
Yeah, this is going to be great. So Aaron, right off the bat, so I see a lot of patients with obesity every day. I do a clinical practice and I do research, but I do a lot of clinic. And there are all kinds of complications that we obviously see. But tell me, why should I care specifically about the liver? So I'm going to ask you that question, but first of all, I'm going to make it interesting. I'm going to put you up. I'm going to put you up against a clock, in fact. So you'll have about 2 minutes to convince me why I should care about the liver.
Absolutely. So, Sean, first of all, steatotic liver disease, which is the common associated liver disease with obesity, is highly prevalent and affects about 30 to 40% of the general population of adults and up to 10% of children. It can progress silently to cirrhosis, and many patients are diagnosed only when they present with complications of cirrhosis, when the treatment options are extremely limited. So there is a missed opportunity to intervene at a point in time when you can actually reverse the disease. And this is particularly relevant because there are now approved therapies for aggressive forms of the steatotic liver disease that we call at-risk MASH, thus providing an opportunity to intervene in these individuals and prevent them from progressing to cirrhosis when we have very limited options for them.
Actually, that is absolutely terrific. You did better than two minutes. You were at a minute, so clearly you are on track. And so it's clearly very important, going all the way from MASLD to at-risk MASH to even MASH that we're hearing that many of these can be silent and then eventually lead to a number of complications such as coronary artery disease, etc. So it's clear though that as well that obesity itself, the prevalence is increasing worldwide. And if there's a direct infiltration of fat cells into the liver, this results in the steatosis or the fatty liver that you were talking about. But when and in who do we get to liver scarring and tissue damage? That's what I frequently want to know. So why is that so concerning when we get to that liver scarring and the tissue damage? Again, another 2 minutes on the clock for you, Aaron.
Thanks, Sean. I think it's important to remember two things. First, that this is not only a liver disease that progresses to cirrhosis, but secondly, having fat in the liver increases the likelihood of having a lot of other end organ diseases. What do I mean by that? I mean that you have increased risk of having cardiovascular outcomes, developing type 2 diabetes, chronic kidney disease, etc. So there is a ripple effect beyond the liver as well. And a key thing to remember is that the more features of metabolic syndrome that you have, the more likely it is that you have the more aggressive form of fatty liver disease, that we call steatohepatitis. And that's the form that's more likely to progress to scarring. And there are now simple tools to identify who is at risk, such as the FIB4 test, which is called also known as the fibrosis 4 test, based on age, AST, ALT, and platelets, which give you a number. And if it's less than 1.3, you can reassure the patient that the liver itself is relatively not scarred, even if it might have fat. But if it is more than 1.3, then you have to do additional testing to better understand where the liver is in its journey from normal all the way to cirrhosis, so that we can figure out the appropriate interventions.
Wow, that was excellent. That was perfect, and that was 90 seconds. So it was actually right on track. So obesity, we know, is a truly chronic and progressive disease, which fortunately we now have interventions that actually work. Interventions such as pharmacotherapy and also bariatric surgery, and they've had a significant impact and allowed patients to make these healthier food choices with fewer calories. And the big deal here is not just that they're making healthier food choices and having fewer calories, because people can do that relatively easily. The idea is that they do this over a sustained period of time, and that's the important part. So we have this combination of being able to get enough weight loss. So what we wanted to see was weight loss not just in that 5% range, but in the 10, 15, 20% range. This is what we call categorical weight changes. And as we've had new developments of a number of these medications, we've gone from just getting 5% weight loss to 10, 15, 20, and even 25% weight loss changes. And the reason why this is important is because it allows us to decrease the complications that we couldn't previously. When we got to greater than 5%, we got the glycemic the control. So the hemoglobin A1C, the blood sugars came down between 5 and 10%. But if we want to look at coronary artery disease, obstructive sleep apnea, osteoarthritis, and MASH, MASLD, we need 15, 20% weight changes, and we need it over a sustained period of time. Some of these newer interventions are actually doing that. And so this is great. We see that the trials have made a significant impact. The comorbidities are getting better and better. So, Aaron, as a liver expert, can you tell us what losing weight can do in terms of treating liver disease? And how much weight do people with obesity need to lose to see the benefit in terms of liver health? And finally, can this reverse obesity-related liver damage? A couple questions there. You've got 2 minutes to answer these questions if possible.
Let me try my best to. That's a lot to cover, but let's go. So, again, to start with, first important point to remember is that there is a lot of common biology at a cellular level. Whether we are talking about liver disease, we're talking about atherosclerosis, we're talking about diastolic dysfunction, we're talking about chronic kidney disease, where you have a metabolic injury that leads to cell stress, which leads to cell death. And the cell injury triggers a sterile inflammatory response through the innate immune system, which triggers a scarring reaction, eventually leading to dysfunction of each organ that is affected. These organ dysfunctions can follow different time courses. So we often see cardiovascular disease as the immediate threat to life, but then the liver disease and kidney disease catches up later on. And so when we think about treating this, if the root cause is delivery of excess fatty acids and lipotoxic sugars to each of these organs, it's really, about the biochemistry of what is happening. And it's not simply a matter of weight more or weight less. Within the adipose tissue compartments, the visceral adipose tissue compartment is particularly important as a source of adipose tissue inflammation, where in addition to the sugar and fats that are released due to insulin resistance, you're releasing inflammatory cytokines. And together, all these organs are bathed in this mix. Now, what that does is that it damages the liver. And for liver disease, you need at least 5% weight loss to improve the steatosis, which is the first, thing to improve. But to improve the steatohepatitis that we talked about, you need at least 7%. And to improve scarring, you need 10% or more weight loss. And certainly, as you pointed out earlier, more is better. So you really hit that asymptote where weight loss and clinical benefit level off is 20% or higher. Now, having said all of this, it's also very important to understand that there are now recent data coming out that even in those who get very small amounts of weight loss, there's a substantial benefit in terms of clinical outcomes. So the with the newer therapies that are targeted for weight loss, even in those who don't get the weight loss, we're seeing a substantial benefit because it's improving the health of the adipose tissue and adipose tissue inflammation, which are actually critically important as drivers of atherosclerosis, heart failure, liver disease, chronic kidney disease, etc. How did I do on time?
Terrific. That was excellent. The reason why that was actually was 2 minutes and 50 seconds, but you had extra time made up from the questions before that. So,
Perfect.
so you're on track. All right. So what we're seeing here is that what I've heard is that there's a large benefit from the sustained weight loss, even starting at that 5%, be getting more and more at 7 and 10 at 10%. And oftentimes this gives us a buffer as well. When people get up to that 10, 15% weight change, because they can go a little bit back and forth, they have a little bit of a buffer. Sometimes 3 and 5% weight loss, patients may frequently go back and start to go back to where they were before, and they don't have as much of a buffer. So that's why we like seeing 10, 15%. So, and I did mention that some of the newer weight loss medications are coming, they are available, but they're even more in the pipeline. So we're normally talking about the regulation of these NUSHs, or nutrient stimulating hormones. And the most famous one is GLP-1. And we hear that all the time, GLP-1. But are there other hormone regulators that we think will work better in MASH versus other complications of obesity? And again, another 2 minutes on the clock, Dr. Sanyal.
Thanks, Sean. I think it's really fantastic that after many decades of trying, we now have 2 drugs that are approved for the treatment of MASH with fibrosis. And these are resmetirom, which is a thyroxine beta receptor agonist and directly targets the liver. And the other drug is semaglutide, which is a GLP-1 agonist. There are, just based on what I previously described to you, where you have metabolic injury that leads to cell stress, cell death, that triggers inflammation and then scarring. Knowing these 4 pillars has given us targets that are directed to the metabolic root cause, cell stress, inflammation, and scarring. Now, the ultimate readout for the liver disease is scarring, and progressive scarring leads to cirrhosis. So there are not only tremendous benefits with the GLP class of molecules, but GLPs do not have receptors in the liver. So much of the benefit is due to its benefit around outside of the liver. And that can be further enhanced by GLP-GIP, such as tirzepatide. And then there are new molecules which target glucagon, which is directly in the liver and targets sort of the liver injury itself and may potentially have better benefits on fibrosis. The trials are ongoing. And now we have triple agonists, which have GLP, GIP, and glucagon. And there are other classes of hormones, such as FGF21, which have dramatic effects on fibrosis. So tremendous amount of activity in this field. I think these are really exciting times because, as you know, an oral form of semaglutide is now available in the US. And then also orforglipron, which is another oral GLP-1, was just approved for obesity. And these are likely to be very impactful for the field. I'm hoping this will increase access to care so that the people who are likely to benefit will actually be able to get these drugs.
Absolutely. You are just as excited as I am about this, but we're also really excited about what is in the pipeline. So it was great to hear about these new NUSHs, again, nutrient stimulating hormones besides GLP-1. So GIP adding to the mix, but glucagon also adding to the mix. So the new kid on the on block, really, and being able to add in this glucagon aspect and seeing what it can do besides the weight changes, going to the dealing with the steatosis and whether there's other mechanisms that are involved. We're learning so much. And so Aaron, thank you. We've discussed obesity pathology, treatment options, but more so, we've done a deeper dive into the complications of MASLD and also MASH. We're on the cusp of these improved treatments, and this is absolutely great news. And so, Aaron, again, thank you for this great discussion that we've been able to have to today, and for everybody listening, to the audience. Thank you for participating in this activity, and please continue on to answer the questions that follow and complete the evaluation. Thank you.
Thanks for having me.